Welcome to Echo HBV Workshop. This is Workshop B, Module 2, so it's our second week. So happy to have all of you back with us. Hi, Dr. Pan, how are you?
Hi.
And thanks again to my colleagues, Ali and Jill. You'll find them with the same virtual background, so it's easy to spot them. So hi, Debbie, Paula, Roma, Antonio, Dr. Nadu. Got some more folks trickling in. So we will begin, as always, with a quick pre-test poll, trying to get a feel for our knowledge pre-presentation, and then we'll see those questions again at the end. Hi, Angel. How are you today?
Yeah,
Uh,
Good. How are you?
Great, thank you.
uh,
Okay, so why don't we start with our pre-test poll. Okay, first one is I defer HBV treatment for my patients with cirrhosis if their ALT is normal. Would you say always, often, sometimes, rarely, or never? And you'll need to scroll down for the second question, which which of the following is generally an indication for initiating treatment for hepatitis B? Would you say measurable HBV DNA, negative for hepatitis B surface antigen, hepatitis B surface antibody positive, or elevated ALT? Give everyone a moment to answer those couple questions. And again, after the presentation by Dr. Pan, we'll be moving over to the Q&A. So any questions that you might have about what was just presented or hepatitis B in general, you can always put it in the chat. You can put it in while you're actually watching the presentation. This way we can move over to the questions right away. Do have a question that Joseph from last week had a question about, so we'll address that one first. And then we'll move over to the case presentation before we wrap things up. So for folks that are just joining, we've got our pre-test poll up. I'll give everyone another minute or so to answer this one. Thanks so much for joining our second module. 2 out of 4, so we'll be about halfway done after today. That's fine. Okay, I'm going to end the poll. And all right, and I'll move it over to Dr. Pan, who's going to talk about our second module.
Hi, good afternoon. Welcome back. So today we're going to focus on the natural history and the management of hepatitis B. So this is the objective. At the end of this discussion, I hope you know how to optimize the timing for treatment, particularly select the most important criteria, which you have a pretext talking about HBV DNA to enter your patient treatment. And you would understand the goal of treatment is try to minimize the chance to get cirrhosis and cancer. Now, what might be the chance if patient they would not receive any treatment at all? And the lifelong risk of development of the developing cirrhosis or liver cancer is about 40%, pretty high. So later on, we're going to look into what might be the most critical parameter for you to identify those patients actually at higher risk to be that 40%, right? Because 60% they may not have a cancer or cirrhosis, but how you can identify that 40%. So we're going to show you the data about HBV DNA. It's the most important factor contribute to developing of liver cancer and cirrhosis. Now, for that 40% who develop complications, of course, you can diagnose them when they have liver cancer or cirrhosis, but it's too late, right? By the time that they got cirrhosis, they compensated, they probably will die 50% chance in 5 years. And liver cancer still have no cure unless you get liver transplant in most patients. Even you have a patient have a resectable liver cancer, 5-year recurrent rate is 70%. So it's not a good news for those patients who manage their hepatitis B just for observation. And the worst thing for Hep B is they're usually asymptomatic until develop the complications. So here shows Hep B as a silent killer, and majority of patients have no symptoms unless they get into the complication. That's why screening is most powerful tool to identify first who got infected, and later on I'll walk you through how we can select those patients infected with Hep B to enter treatment. Now, the screening for the new CDC guideline, as we mentioned in the module 1, the new guideline indicate that you should not just use one test. In the old days, we used just surface antigen. Now, they want you to do 3 test panel, including surface antigen, core antibody, and surface antibody. We'll get into the interpretation later on. So what does it mean? E antigen and HBV DNA, you don't need to do it in a screening test. But if patient have diagnosis with hepatitis B, that means surface antigen is positive already. The next step is try to get the DNA. Remember, we mentioned that DNA may be the most powerful predictor for the complications. So DNA measurable, you trigger the next step for the evaluation of taking therapy or not taking therapy. Now, when you get the 3 panel back, how would you interpret that? What would you explain to your patient? What's going on here? So let's go one by one. If you only have surface antigen positive, all the other things like the antibodies are negative, but the core positive, that means you have 2 possibilities, either acute infection or chronic infection, right? When patients get infected, they got surface antigen replicating the viral protein. And also the core antibody, which is a surrogate marker for core antigen, because in the blood, core antigen is not water soluble. You cannot detect that in the blood. But core antigen actually can be detected by the liver biopsy. So for most of you in the primary care setting, not in research setting, you probably couldn't detect core antigen. That's why core antibody is surrogate marker. So what if your surface antigen is negative, but you have the antibody? Then it really get down to the core. If the core antibody is still there, that means the virus is still there. But the good news is, after infected, your body immunity get under control and develop the antibody, clear the surface antigen. So in this scenario, both surface antibody and core antibody positive, but your surface antigen negative, you still got the infection. Any core positive, you still get the infection. Any surface antigen positive, you got active infection. So with the core antibody, you still get the infection, but well under control by your body. The name that in the past we saw resolve infection, which could be misleading, and patient would say, hey, I have no problem. No, you still got the infection. The new terminology is immune control or inactive infection. For this kind of patient, if they got chemo, they got immunosuppressive therapy, they can still fare back up to the surface antigen positive. Now, the most challenging interpretation is only the core antibody positive, everything else negative. So this scenario, like I said before, still get infected, but immune under control. That's why you don't get the surface antigen. And you didn't get the core antibody, the surface antibody. So it's an immune control, but not as good as those immune control with the antibody, right? So in this scenario, sometimes I got question for vaccination. Now, what if this patient still have core positive, would be a false positive? I need to give them vaccine. Chances are very rare they are false positive. So majority of those patients, you don't need vaccine. But the new CDC guideline emphasized that if core positive in the background of patient had no risk factor for hepatitis B, that means they have no family member they haven't been exposed to, then it could be a false positive. Only that small subset of patients, you need to get them the vaccine. Now, another interpretation, everything 3 panel is negative. That's easy. Never get exposed to the virus, you get the vaccine. So I spend extra time on this slide. I think it's very important. Now, the others are easy. Hep B is preventable. You get the vaccine can reduce the infection, and subsequently, no infection, no cancer, right? No Hep B related cancer. So the laboratory showing the surface antigen positive, your next step would have to do additional tests to make a decision whether to treat it or not. Now, in your pre-test question, we ask, would HBV DNA or ALT or E antigen or surface antigen? They are not critical. When the surface antigen positive, the DNA is the most important parameter to tell you this patient most likely get treatment or not. A high DNA definitely can increase the chance of infection, the complication. Now, what are the role of ALT in terms of weighting this patient should go for treatment or not? The ALT implies that the liver may get damaged, but the other way around, if the liver damage from the other disease like fatty liver or even eating herbal medication, taking them can cause ALT elevation. So ALT is not reliable, but it is a system factor help you to make a decision. You got a high DNA and plus liver damage, there is no reason you should not treat the patient. So this is the most important slide I want you to remember. When patient diagnosis surface antigen positive, they have the virus actively infected. The level of HBV DNA actually reflecting here and showing the complication of cirrhosis and HCC. If you look at cirrhosis, more than 1/3 of those patients with high DNA, more than 1 million, they got cirrhosis. So the cutoff here is when you see 300 to 9,000, you start to see 6% of cirrhosis and 1.4% of HCC in the long-term follow-up 13 years. So therefore, the HBV DNA is the most important indicator to enter those patient treatment. We'll get you the cutoff number. So you got a ballpark number 300 to 9,000. And later on, we'll show you the guideline, what number cutoff you should enter the patient treatment. So if you put the patients in antiviral treatment, in your module 3 and module 4, we'll talk about what therapy you select. But no matter what you go for, chances are it will decrease the DNA and subsequently decrease the complication and eventually lead to suppress the replication and cause surface antigen loss or convert it to the antibody. So this is just the review of natural history. If a normal liver get infected with hepatitis B, you become chronic Hep B, then 40% of chance you develop cirrhosis and cancer. It's reversible if you provide the treatment, antiviral treatment, suppress the virus. It doesn't matter the patient at the stage of fibrosis, not cirrhosis yet, or even get to the cirrhosis, they can still reverse or stabilize them. So here's the treatment algorithm, simplified one. This slide gives you the most important cutoff value. When patients have hepatitis B evaluation, you know that they infected with hepatitis B, show it in the surface antigen positive. First thing you want to look at is DNA. Even ALT elevated, if there is no DNA, you don't treat them, right? because their chance to develop cancer is much lower, as you see in the Taiwan study. But if the DNA more than 2,000, definitely you need to enter the treatment in the new guideline. And even in this simplified level, you want to get another factor like ALT elevation, but it's not a must. You see there's an and or. So even it's or, you can consider. But most important is DNA, not necessarily DNA plus ALT. All right, so the current treatment paradigm actually is moving towards the finite treatment, the duration, and reduce the liver cancer. The old treatment goal is just try to get the suppress the viral load, but the new treatment, there are many new medication developing in the phase 2 and 3 is towards get the patient to treatment in a year or two and then can stop the therapy. So the question is, since it's an infectious disease, and why we cannot just treat everybody like HIV? Well, bottom line is, if you look at the review study, the Taiwan study, those patients have HBV DNA less than 2,000, and their disease progression is very slow and also have a much lower chance to develop cancer cirrhosis. And considering all the treatment now is not cured, so you may have to offer a long-term treatment and actually not cause a fat death. So we're waiting for the new cured therapy like Hep C. You probably need to treat everyone. Now, the current answer is still not treating everyone. We select patients with HBV DNA more than 2,000, or they have cirrhosis already. Now, at what point this patient might be benefit more with such specialist care? Here list some of the scenario that you need more complicated team care. For example, if patient have cirrhosis, particularly decompensated, you need a specialist and evaluate whether they qualify for liver transplant. And if they have co-infection, for example, co-infected with HIV, you need to have multiple medication, cocktail treatment, not just never put anti-HBV monotherapy on a co-infected with HBV patient, because that monotherapy can cause HBV drug resistance. The others is like patient, they have immunosuppressive therapy, hepatitis B reactivation. You probably should consider get that patient to a specialty as a team care so we can handle more complicated cases. Here, just showing you that even patients are less than 2,000 HBV DNA, you don't need to treat them now, but you need to monitor them, at least for cancer screening every 6 months, and also monitor HBV DNA 3 to 6 months. If they elevated, they probably normal today or undetectable today and flared up like tomorrow. So anytime you see HBV DNA more than 2,000, you may consider the treatment. So with that, I end my presentation.
Okay, thank you so much, Dr. Pan. Great presentation. And I'd like to welcome our other faculty, Dr. Carla Coffin, who is fortunately able to join us today. So Dr. Coffin, this is a new group, so why don't you do a quick introduction of yourself?
Yes, thank you. My name is Carla Coffin, and I'm a hepatologist and a clinician scientist at the University of Calgary in Alberta, Canada. So it's my pleasure to be here today.
Thanks so much. Happy to have put a message in the chat. If anyone has any questions, feel free to ask them. You can put those in the chat. We've got some, actually one. Thanks, Dr. Pan. That we didn't get to answer last week. So I will begin with that one. And also feel free to turn your cameras on if you're able to, and you can come off mute and you could ask that question yourself too. All right. So the first one, I don't think Joseph is here today, but he did ask, the CDC now recommends universal screening of all adults for hepatitis B surface antigen, hepatitis B core antibody, and hepatitis B surface antibody, regardless of risk. Do we know if cost of screening tests is covered by CMS for Medicare or Medicaid?
I can talk about the U.S. situation. Yes, it have been covered by Medicare and Medicaid, at least in my patients. The commercial insurance before the CDC guideline, there are certain insurance may not cover the 3-panel. They just ask for one. But I would expect that with the guideline just published a month ago, and this is going to be open up.
In Canada, it is covered. If it's ordered by your physician, then it's covered.
Good to know. Thank you both. Okay. We have a question in the chat. How often does acute hepatitis B progress to become chronic? In other words, what is the natural history of hepatitis B without treatment?
So I can try to address that. I think you are asking two questions, two separate questions, because the risk of progression to chronic infection is actually related to the age of which you're exposed. So infants or children under the age of 1, especially, if they are not vaccinated, then they have a greater than 95% chance of becoming a chronic carrier, so lifelong infection. If you're an adult and you're immunocompetent, meaning you don't have any immunosuppressive conditions, then you have a high chance of clearing the virus and developing what we used to say natural immunity, but its more correct term is to say have immune control. So you clear surface antigen and you develop surface antibodies. So greater than 98% by some estimates. So that's the risk of progression to chronicity. The second question is, if you already have chronic infection, so for example, a baby that exposed at birth and became a chronic carrier, your risk of progression without treatment, by some estimates, it could be 25 up to 40% could develop cirrhosis. There are factors that can affect the risk of progression in terms of other coexisting liver conditions. So if you have fatty liver disease, if you have co-infection, and if you are on treatment, then this would definitely reduce your risk of progression to cirrhosis and liver cancer. It also depends on age and family history and certain viral factors, but that's probably a bit more complicated to talk about.
Yeah, and also in co-infected cases, particularly in Delta, depends on where you practice. Like in the northern part of Asia, like Mongolia, there are 40% of Delta co-infection, and the disease progression is huge. It's like triple the risk of develop cancer and cirrhosis. HIV patient also can accept that progression.
By some estimates, with Delta, progression to cirrhosis within 2 years. Some studies have shown that. Yeah. Very fast.
Okay, thank you both. And we actually have some questions that we addressed on Tuesday with our other groups, so might be good to ask them here too. And again, I know some folks joined a little bit later, so feel free to put any comments, any questions in the chat, and we could read those aloud. Dr. Coffin, Dr. Pan, I will put it in the chat so everyone can see. What testing is required after someone has resolved acute hepatitis B infection?
I'll try to answer that. For acute hepatitis B infection, I would just follow those patients and see if they become chronic, right? Even though Dr. Coffin mentioned that if you have a very immunocompetent patient, and the chances probably about 5% or even less. But most important thing is after 6 months of their acute onset of hepatitis B, you're supposed to check the whole panel and see if the patients actually turn into a chronic case. That's something that you don't want to miss. Even the patient may not qualify for treatment, we just discussed in the slide, they probably need to be monitored, whether later on they may become active disease and then need require treatment, or at least probably need a cancer screening. So I think the first priority for me is try to determine if the patient actually turn into chronic, even though it's different odds ratio. It depends on the condition that they have. Particularly in immune incompetence patient, they may have more chance to become chronic. That's a first priority. The second one, I probably would see if the acute infection actually caused some severe damage from the liver. Oftentimes, patient recover well, but it's not unheard of that patient may develop fulminant hepatitis and then die, or even they are not fulminant hepatitis, but subfulminant, they have a severe liver damage, then it would be a concern because you get a very bad shaped liver full of scars, and they have significant fibrosis. And I probably need to monitor if this disease progression even after they have been resolved, not become chronic, probably need to be addressed. For example, if they have stage 3 fibrosis, I probably need to monitor their progressive cirrhosis and address the other issues that may cause a liver problem, like fatty liver, gaining weight, drinking alcohol. So those are the two things that I might be focused on. I'd love to hear Dr. Coffin and how you manage your patient after acute infection.
Well, I agree with you that if it is a otherwise healthy, immunocompetent person that somehow or another got infected as an adult, in my practice, I've seen it from people with unprotected sexual contact, then the test to confirm that they've cleared the infection is after 6 months to check the hepatitis B surface antigen, the hepatitis B surface antibody, and just for completeness, the hepatitis B core antibody. It's good to do the liver panel like the ALT, as you mentioned, because we want to make sure that there's no significant liver damage or significant inflammation. Sometimes, rarely, you can get a very, very powerful immune response against the virus when it's trying to clear, called a cytokine storm, and that can lead to fulminant liver failure and even needing a liver transplant in rare circumstances. Most people recover, and you do these 3 test panel to make sure that they have recovered. The second thing you need to keep in mind is that there can be low-level virus still hiding out inside the liver after you've recovered from acute infection. And these people may be at risk of reactivation if they become immune compromised. So if later on in life they get chemotherapy or have a transplant for another reason, then you need to monitor them, and they might need prophylaxis or antiviral therapy to prevent reactivation. It's a little complicated in that people that have acute infection and clear it in adulthood, maybe the risk of reactivation is less compared to people that had chronic infection for their entire life and then cleared it. But to keep it sort of simple from a primary care perspective is just to monitor these people because they have been exposed to hepatitis B.
Yeah, with that, I just want to circle back to our module 1, and don't forget to screen those patients' family or whoever that might have a risk contact with these acute cases. With this patient might be transmit the disease to the others. So I would not only educate the patient for his disease per se, but for monitoring and all that, but I would urge this patient to talk to the close contact or the people around him or her that might have a risk to contract the virus and screen them.
Thanks, Dr. Pan. Thanks, Dr. Coffin. Angel actually asked, what are the prophylaxis of hepatitis B?
I can answer that question. So two types, I guess, of when I use the word prophylaxis. One is just to prevent getting hepatitis B, period. So that would mean getting the hepatitis B virus vaccine. If you are a baby born to a mom with hepatitis B, you should get the hepatitis B vaccine and also give hepatitis B immune globulin or passive antibodies to the baby. The second way I use the word prophylaxis, I apologize if sometimes it's confusing, is if you already have hepatitis B or been infected with hepatitis B in the past, and you want to prevent the virus from becoming more active or reactivation, and then we give antiviral prophylaxis, meaning nucleoside analogs, so entecavir or tenofovir, as prophylaxis to prevent the virus from just becoming more active and replicating faster. So I should probably change my term and say prevention of hepatitis B and prophylaxis against reactivation to be more clear.
I think that's a great question. I love the answer. I think Dr. Coffin gave you a full spectrum of management hepatitis B, prevent the patients get the novel infection of hepatitis B, and prevent those patients who have hepatitis B develop complications. That definitely is more important to watch out. If you want to just focus on the novel infection, then you can probably get a little bit into a subgroup. I would supplement that information to you and see if it truly meets your need. We're talking about the novel infection. That means the patient never have a Hep B. Now they might have two scenarios. One is they might get exposed to a Hep B infected individual in a very subtle way. For example, they have family contact, or they have husband and wife, or engaging MSM, high risk behavior, but they don't have hepatitis B. Definitely, I would like you to follow Dr. Coffin's recommendation, get the hepatitis B vaccine. But that's called active prophylaxis. Now, what if you are a healthcare provider, you got a needle stick? Then you have a high risk of exposure. Then you may have to combine the passive and active prophylaxis that you may need to get the HBV. So talking about the novel, you can still subcategorize that using a mono active prophylaxis, or you need to do a combination of passive active. In high risk, for example, prevent mother-to-child transmission, because we talk about during delivery, the placenta tear and the mother's blood will go into the baby, or in a healthcare provider setting, they got a needle stick from a Hep B patient. So it's very high risk, then we encourage you to use a combination, passive and active prevention method, prophylaxis method to combat the de novo infection. So I hope those information may help.
The only maybe additional point is that I think nowadays most healthcare providers are vaccinated against hepatitis B, and if there's documented immunity, which I believe most places they require that testing just to confirm that you've had a response to the vaccine, then hopefully that they can be reassured that a needle stick from a Hep B positive person is not going to be a risk and not need to give HBV if they've had documented immunity. Do you agree with that, Dr. Pan?
Oh yeah, I think it just it's not uncommon in the US. I don't know about Canada. I'd love to hear from you. And some of my colleagues refuse a Hep B vaccine, and the hospital would just still okay with that as soon as you understand the reason. Then you have to sign your agreement or your so-called the consent of not having it, but still get into. So that means if you got happy, you don't get worker compensation and all that. I mean, because you refuse to take the preventive method.
Oh, okay. Yeah, I understand.
Okay, thank you both. So I asked, just to clarify, do we need to continue monitoring hepatitis B panel and screening for cirrhosis and hepatoma after a patient has cleared his hepatitis B surface antigen? If so, how often?
So after they have cleared surface antigen, and I would repeat it once at least just to confirm and do the surface antibody as well. If they have cirrhosis, then the guidelines recommend, yes, they should have ongoing monitoring with ultrasound and alpha fetoprotein every 6 months to screen for liver cancer. If they don't have cirrhosis, there has been some published studies, I believe, from Taiwan, showing that younger people, especially under the age of 50 or 40, if they've cleared surface antigen, they do not have a higher risk of liver cancer compared to the general population. So you don't need to do hepatoma screening if they don't have cirrhosis and if they're younger when they clear surface antigen. But there's still evolving data about this, and we're looking at other factors like what if they have coexisting fatty liver disease, and what, how does that potentially impact the risk of liver cancer development? What do you think, Dr. Pan?
Yeah, that's a very interesting topic. I totally agree with you. There are not a whole lot of data. Good quality of data looking at this subset of patients and how high the risk they have. But in general, the data, retrospective data, and they suggest it's low. It may not be cause effective, particularly in those patients. I think it's a lean study in Asia and showing that it's age 40, before 40, you clear the surface antigen and the complications rate is negligible. If you are over 40, even you clear the surface antigen, it's a considerably significant number of patients develop cancer. So that's for the cancer risk. And cirrhotic patients definitely is a lifelong screening, even though their surface antigen negative, but don't forget they may have burnout syndrome. That means they have a bad liver. So their surface antigen negative doesn't mean their disease is getting better. So for any cirrhotic would be a lifelong screening for cancer, and they're cirrhotic already, so you need to monitor them. If non-cirrhotic, I don't have I'm not aware of any data just differentiates the fibrosis stage 2 and stage 3 in surface antigen loss and then how you monitor it. But my personal, based on some preliminary data, I interpret that the fibrosis at stage 3 still have a significant chance to develop cancer. And also some patients, they might have disease progression. So I routinely monitor fibrosis at stage 3, even after surface antigen loss. Stage 2, I probably would drop if they're young. I wouldn't routinely screen them cancer or unless they have any risk factor to have disease recurrent. I probably just see them once a year for disease reactivation.
If I put in the chat box a website that was developed by my colleague at the University of Alberta, cirrhosiscare.ca, and it has information for healthcare providers as well as patients and non-specialists for people living with cirrhosis. So that has a nice sort of information about what you should do when you have cirrhosis for monitoring. So no matter what the cause of cirrhosis, or whether it be Hep B or other diseases. So cirrhosiscare.ca, it's a really nice website if I don't mind promoting it. Yeah.
Right. So I got a question that Dr. Pan, my titer is 7.8 for immunity to Hep B. Do I need to get a booster vaccine? So actually there are several larger studies done and document that if you are suboptimal, that means not get up to 10, it's worth it to try to either you go another round of vaccination or double the dose or switch to other brand. Now you have 2 brands in the US. I'm sure in Canada, you probably can have 2-dose vaccine, the new one. So you will switch brand and try to boost up to 10. But once you reach 10, even later on, your titer decrease is not a big problem because your immune memory will be there, and if the virus gets in, you will respond adequately. So for this case, I would presume you're not immune compromised and you're a healthy person. I would try for another 3 shots or even double the dose. Pick one way or the other and try. But no matter how hard you try, some study, not a whole lot, show that about 3 to 5% of those patients will never get it up there. And if you're not in a high-risk environment, it's still okay. So I think it's just taking a personal precaution if you cannot have the immune get up to the optimal level.
I believe she said she did have titers of 10 5 years ago. So this would mean she did have a.
Okay. So you don't need anything.
No. There's a nice paper published in Hepatology last year by Brian McMahon using the Alaska babies that were vaccinated against Hep B at birth. And after 40 years, they still had protective memory responses to booster. So indicating that basically once you get the vaccine for Hep B, you probably have lifelong protection.
Okay, and thank you to those who submitted questions. I'll look forward to hearing even more questions next week.
Okay, so the patient is a 55-year-old woman whose mother died from Hep B related liver cancer. On routine physical exam and laboratory tests, she was found to be hepatitis B surface antigen positive, hepatitis B E antigen negative, and E antibody positive. And as expected, her Hep B core antibody was positive. Her viral load was very high, so 6.3 logs, or greater than 7 million international units per mil. And she was started on tenofovir antiviral therapy. After 9 months, she started developing lumbar pain. She had great difficulty walking and could not sleep. What advice do you recommend, and what comments do you have about this case? Maybe first of all, I could ask, do you think it was a good idea for her to be started on antiviral therapy? And if yes, then why?
I think it's reasonable to start antiviral treatment. She has very high viral load. She has family issue of hepatitis B related liver cancer. So I don't think there's any reason not to start her on an antiviral treatment. That's my thought.
Yeah, Dr. Mui, I totally agree with you. I think what is so important in this case, he had a viral load of 5 logs, 6 logs. It's over almost 1 million, right? So if you look at the slide that we just presented, the Taiwanese study, the review study for 13 years follow-up, the cirrhotic chance is like 30% plus. Cancer is like 10% plus. If you don't manage the HBV DNA, which is the most important indicator for complication, and you may end up the patient get another 10 years, we'll get into that. So I totally agree with you. The most important thing is to look at a viral load. Now, what if, let's twist it a little bit. What if the patients have no viral load, undetectable, surface antigen positive, but just the ALT is like 100, normal is 40. So would you approach this patient the same and offer TTF treatment at that time? Only the ALT.
Elevated ALT is good enough indication. If she has hepatitis B and she has elevated ALT, especially has family history, I won't hesitate to give her the antiviral treatment.
It could be a fatty liver, right?
Yeah, you
The only scenario with a very low DNA, not approaching 2000, but you still offer treatment is what? When the patients have cirrhosis, right? If they got cirrhosis, then even though the blood is not showing a high level of HBV DNA, but I want to prevent the decompensation, prevent the more complication. I want to offer antiviral treatment and clear the intrahepatic HB virus there. So in that scenario, that's regardless the ALT or DNA, I probably would offer. Besides that, majority of patients you see in your clinic, if you're not working in a transplant center, they are not cirrhotic, then you do have to look at the DNA. DNA is the most important thing.
The problem with the blood test is that you're only sampling it intermittently, like every 6 months. But what if in between that sampling, the viral load blips up? And then you have a patient who has cirrhosis, and that little viral flare could precipitate decompensation. So that's why we got to put them on the drug and just keep them really, really suppressed so that they don't have any risk of those blips.
And Dr. Naidu in the chat also said that this could be fatty liver.
I agree.
Yeah.
So even a surface antigen positive, it's not the critical criteria to enter the treatment immediately, right? So you have patients non-cirrhotic, but only surface antigen positive, or even E antigen positive, but their viral load is very low, below 2000. You probably want to wait a little bit. Maybe their E antigen positive will turn to negative soon. They're in the middle of clearance. You can wait a little bit. But if the viral load is low, is high, regardless the E antigen status, even E antigen negative, you still end up to get complication if you don't treat. So surface antigen, E antigen, ALT as a solo parameter, it's not a good indicator for you to rush your patients to treatment. You have to overall look at the picture, particularly most important HBV DNA. Unless they're cirrhotic. If they're not cirrhotic, then you have to look at the DNA. So DNA, among all the other virological parameters, DNA is very important.
We didn't go past this case in our last lecture with the lumbar pain. Is this something that would want to discuss at this point, or just sort of talk about the treatment? Like what could be causing her back pain and so on? Maybe next week we talk about that. I don't know. I don't have the other the next slide for that case.
Yeah, let's ask the group. What do you guys think about the back pain? Why the patient have back pain? Is it from hepatitis B, or from the treatment, or from something else?
I think our next module we cover a little bit about the drug side effects, right? As one.
Just a quick question. When you mention ALT above upper limit of normal, do you mean 2 to 3 times above the normal range, or do you mean just slightly above upper limit normal?
What the ALT was? What was the actual value of the ALT?
Yeah, the ALT is at when the ALT is above normal limit. Do you mean 2 to 3 times above normal limit, or just say a few units above normal limit?
I probably in this case it meant above the normal limit, but ALT is less important for treatment decisions in this case because the viral load was so very high and they had the family history of liver cancer.
No, so, I mean in general, when you mention.
Oh, in general?
Yeah.
Yeah, in general, we use just above upper limit of normal.
Just about say 40 or 36, something like that, right?
Yeah, yeah.
Okay.
I think maybe our next week's talk, we'll talk more about monitoring on treatment and other things to consider, you know.
Yeah, it's like a preview
Right.
of next
Preview.
module, and you get your
Yeah.
curiosity.
Yes.
Now, if you really want to stretch the other course for back pain, not that common, but sometimes you have extrahepatic manifestation of hepatitis B. They may have glomerulonephritis due to immunocomplex deposit in the kidney. So it doesn't hurt when patients have, even before the treatment, they got back pain, they got urine changes, do some nephrology work up, and see if this might be, in fact, one of the unusual presentation of hepatitis B. But in this case, it's not the issue because initially patient didn't have back pain, but after starting in tenofovir, so more towards the side effect of tenofovir. But we'll get into more unfold the treatment side effect, next module.
Yeah, I would also be a little thinking, family history of liver cancer, even though they're on antiviral therapy, there's still a residual risk of liver cancer and potential, any risk of, aggressive tumors and metastases. So all of these, worst case scenario that you might want to be keeping an eye out for, which of course we do because we need to do ultrasounds anyway, even if they're on treatment.
Thanks, Dr. Coffin. Thanks, Dr. Pan. All right, and thanks for the questions. I think we're going to move over to our post-test poll. So why don't we do that? And again, if you're on a device like a phone or a tablet, you may have to scroll down. The first one, as a result of this activity, how confident are you now in recognizing which patients with chronic hepatitis B may defer treatment? Much more confident, moderately confident, somewhat more confident, or not more confident? And our second question is, which of the following is generally an indication for initiating treatment for hepatitis B? Measurable HBV DNA, negative for hepatitis B surface antigen, hepatitis B surface antibody positive, or elevated ALT? Give everyone a moment to answer those questions. And again, thank you everyone so much for joining us. Special thanks to Dr. Pan, Dr. Coffin. Dr. Naidu said, let's get 100% again. Yeah, exactly. Tell you that we're getting closer. Definitely want to beat that those workshop A people or their Tuesday people. So give everyone another moment, and Jill will put the link to the evaluation in the chat at this time. And just a reminder that you do need to be logged into your DKB Med account in order to access that evaluation. And we'll also send a link to that evaluation in your email, and you'll also get a copy of the slides as well from today's presentation. We'll see you next time for Module 3. So we're just about halfway done. Not just about, we are halfway done with our modules. Okay, and Jill put that link in the chat. And let's end the poll. Okay, it looks like we're more confident, which is wonderful. And again, I think I mentioned last week, we will be sending out a survey following the last module. So hopefully you're even more confident then, and always greatly appreciate any comments that you might have for us. Okay, and question number 2. 80% said measurable HBV DNA. Dr. Coffin, what's the correct answer to this one?
Yes. Yeah. Detectable HBV DNA is the most important factor.
Yep. Dr. Naidu was really hoping 100%. So I think we got 100% last week. So there's always next time. So again, but really Great, everyone. You're definitely retaining that information. So again, be on the lookout for the slides, and we'll keep this open for about another minute or so. So you can click on that evaluation if you'd like to take some time and do it later, tomorrow. That's fine, because you'll be getting an email from us. So again, thank you both so much, Dr. Pan, Dr. Coffin, for joining us. And thanks to all of you. Keep your questions coming. If you have any cases that you'd like to present, definitely feel free to reach out to us via email at echo@dkbmed.com. Jill will put that email address in the chat as well. All right. Thank you so much, everyone. Echo clap. Take care. Enjoy
Thank
the rest of
you.
your Thursday. Bye.
Bye-bye.
Bye bye.